Bismillah ar-Rahman ar-Rahim. Good morning, my dear vascular colleague. I would like to speak to you today about a debate which I have the privilege of sharing, which is regarding revascularization of long FMPOP disease. Which is better? Is it paclitaxel or sirolimus drug-eluting balloon? My name is Dr. Mohamed Omar Elfarok. I'm a consultant vascular surgeon. The objective of this debate was to see which is a better drug-eluting balloon. Is it the paclitaxel-based or sirolimus-based DCB, which is an important question to debate. And I've actually tried to gather a lot of information. The clinical situation of drug-eluting balloon and peripheral intervention are definitely here to stay because they offer you support for the strategy of leave nothing behind. They preserve the vessel anatomy, minimize restenosis, and in the future they give you a lot of option regarding atherectomy devices and the use of other devices. So definitely they are here to stay. The design of the DCB does not just depend on the drug, but you need a carrier for the drug over the balloon. You need transport to the drug, and you need a rapid drug transfer, and you must have a sustained drug bioavailability. So if you have a good drug, but it cannot be transferred in a sufficient amount to the arterial wall, does not distribute inside the arterial wall, and does not have bioavailability, which is not retained in the arterial wall for a long duration, obviously is not a good option. So performance of DCB depend on the type of the drug, but this is only 25% of the story. Also, you need to learn about coating. That is why not all paclitaxel balloons are the same because of different coating. You need also drug transfer to be studied by animal models and by human experience, and you need to study drug kinetics, how much of the drug is retained inside the body. So all these are very important questions. So this is a summary of paclitaxel characteristic. We know it's a cytotoxic, and we know its a safety margin is 1,000-fold. We know its therapeutic range is small, and it's hydrophilic, and the tissue absorption is fast. So what about the sirolimus? As a drug, we're not comparing efficacy or certain type of balloon. We just are thinking as a drug. I've put here a sheet where if you got an orange color, this will favor paclitaxel. If you got a green color, this will favor sirolimus. So you can see what is favor, let us say, paclitaxel in orange, that it's hydrophilic, it is fast, and have long retained action inside the body. But what is nice about sirolimus, that it is not cytotoxic, it's cytostatic. It is 10,000-fold safety, and therapeutic range is wide, and it also have anti-inflammatory effect, which is not present in paclitaxel. So these are the difference as a drug, but there is something which is called the class effect. What is a class? Class is a group of drug or devices with similar technology, similar action, and like the drug-coated balloon. But there is a class effect, which is a consistent treatment, which is being stable across different devices of the population. But the class effect of drug-eluting balloons are not there, which means they give a consistent effect among all of them, which make the question to be more complicated. So similar performance demonstrated by consistency of safety and efficacy measures is not present in the class. How you can prove it? You go to these steps and nothing else. You do in vitro study, then you go to animal model, then you go to first in human, then non-RCT, and the final verdict by having an RCT. But this is a long journey. This journey can take 5 to 6 years in order to develop. So let us see what is the situation 2023. Does paclitaxel have a class effect? I've summarized 3 paragraphs from very important paper, which all of them say that there is no class effect in drug-coating balloon, which means each drug with a certain carrier have a different design. So this one, not all DCB are created equal, so there is no class effect. A systemic analysis of DCB trials suggests that there is no class effect, so we are sure that there is no class effect. Paclitaxel is not like sirolimus, and even paclitaxel is not like another balloon of paclitaxel. So the answer is no class effect between drug-eluting balloons. Now, the different balloons of paclitaxel have different effects, and this is, I will refer to this paper by Khosrow Niazi from United States. He compared 2 drug-coating balloons from the impact trial and Lutonix, 2 balloons in the treatment peripheral arterial disease with 2 different carriers and 2 different doses, and his result was that result from indirect meta-analysis impact Lutonix using PTA, a common competitor, suggests that there are significant difference in efficacy between the 2 DCPs. There is significant difference in the treatment of arterial disease. Actually, he showed that Lutonix seemed to work much better than impact balloon. So this is extremely important to know. And obviously, we don't take coronary stent and apply them to peripheral, but this one of the trials called SIRPAC trial, which is comparing sirolimus to paclitaxel, and the conclusion was no significant difference. But this is not an evidence that I will use for FEMPOP disease, because totally different territory. Coronary arteries are small, are mobile, are short, so different ground to compare. Sirolimus drug-eluting balloon. Now we have 2 types of sirolimus. One is magic touch, and the other one is solution SLR. The magic touch sirolimus encapsulated in phospholipid nanoparticles, so it have a nanoparticle to release the drug, and this is the mechanism of the transfer. While solution using also sirolimus, but solution SLR use the reservoir coating on the balloon which release the drug. So there are 2 different releasing mechanism of the drug. They use amphiotic coating to enable the drug transfer to the vessel. So you can see not even these 2 sirolimus balloon, I'm sure in the future when they have head-to-head study, which is not at the moment, they will not be equal. This is how they look like. This is the magic touch if you look by the electron microscope, and here is the solution SLR, how the coverage looks like. This is nanoparticle, and this is amphiotic coating. So to proceed, we are going to compare sirolimus paclitaxel regarding drug transfer. You can see this is impact trial, impact balloon. This is impact Lutonix, and this is the solution SLR. You can see the solution, the green part is the transfer to the vessel. So it have a very high transfer rate to the drug. You see the impact is very small, 3%, while Lutonix, which uses less concentration, actually have more uptake into the blood vessel, little bit more, but not like sirolimus. But this is only to give you an idea about the transfer, but it doesn't mean that they are more effective, because there is the pharmacodynamics, how it is retained inside the arterial wall. So I will summarize my debate that there are different DCB with different effects. There is no class effect, which is no unified equal effect to DCB, and sirolimus may have an advantage as a drug, but the paclitaxel is the one which more heavily studied, and we know exactly what it will do, and it is more or less have a similar effect to sirolimus, so the technology at the moment is not offering that much. And you need not just to study the drug, as I mentioned, you need to study the technology for transport, the pharmacodynamic, and definitely each DCB should have been evaluated its own merit on its own body. At the moment, there is no enough evidence to support superiority of sirolimus over paclitaxel as an evidence-based medicine. And I hope with this rapid discussion, you can have a bit of summary about the paclitaxel and sirolimus. So here I've asked the ChatGPT, which is better in peripheral intervention, paclitaxel coated balloon or sirolimus? And ChatGPT have all the medical knowledge since 1964. So the choice of the drug in peripheral intervention on a specific patient and lesion characteristics, sirolimus compared to paclitaxel is just emphasizing the question. He said, explain the mechanism of action of paclitaxel, the mechanism of action of sirolimus, and then he compared both drugs regarding efficacy, features of DCB, and recommendation for a patient with high risk FIMPOP disease. You can use paclitaxel. For patient with high risk of distal embolization, especially infrapopliteal, use a sirolimus coating balloon. And here is some additional consideration. So actually, he did not inform us of any superiority of any of them, but he said this is the situation, which totally agree that at the moment there is no superiority over one drug-eluting balloon over the other. I hope with this I have given you a quick summary of the debate, and I wish you all the best and thank you very much.